This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
Hi, I'm Professor Michael Chapman. I'm Medical Director of Life Fertility Sydney. We've been in business for the last 15 months, albeit the 5 doctors who run IVF at Life Fertility Clinic all have had at least a decade of experience, and some of us have had 4 times that. We're very experienced. So the topics tonight that have been suggested, the first one is ovarian hyperstimulation syndrome. This is probably the worst complication that we get with an IVF cycle. Fortunately, it's rare, and it's getting rarer. When I started doing IVF, we probably had a patient in hospital almost every week with hyperstimulation. As we tried to get as many eggs as possible, we often overstimulated patients. The endpoint in terms of pregnancies was still quite good, but it led to patients being hospitalized, and ultimately around the world, not with us or any patients I've ever looked after, has ended up being fatal. So it's something to be avoided, and we go out of our way to make sure that it doesn't happen. So what is it? As I alluded to already, it's about having overstimulated the ovaries. They produce lots of follicles. Those follicles produce lots and lots of estrogen. The estrogen is not the problem. It is the fact that when we trigger, in other words, give the injection, the final injection that stimulates the final maturation of the eggs, the impact of that using the standard trigger, which was HCG, if you had high estrogen levels and lots of follicles, biochemical changes occurred which led to your blood vessels becoming basically permeable. We do use the word permeable. In other words, fluid leaked out of your blood vessels into your tummy, into your chest, and sometimes even into the brain to cause edema. So that leakage is what is the biggest issue with hyperstimulation syndrome. That can lead to a reduction in the volume of your blood, so your kidneys get starved of circulation, and so you can, in more serious cases, get renal shutdown, what we call oliguria, lack of urine. And that's a bad sign when we have this situation. In the lungs, it can lead to fluid on the lungs, which can lead to respiratory problems. And in the brain, that edema has, in very rare patients, led to strokes. So there are lots of nasty things that can happen with a severe OHSS. If I went back 25 years, those severe cases I talked about probably happened 1 or 2 in 100. It was quite significant. In those days, we tried to, when we got into the situation of lots and lots of eggs, what we would do is reduce the dosage of medication, the FSH medication. We used to give other medications after the egg collection, but ultimately, if it was very severe, they were pretty ineffectual. The most important thing, and it's still the most important thing, is if you do get ovarian hyperstimulation, you need to be looked after by people who know what they're doing. Unfortunately, a number of the very bad cases of OHSS are where intensive care doctors, not understanding the physiology that I just described, try and treat the reduction in renal function by giving diuretics, and that just actually makes the situation a lot worse. So, if you ever get it, go to hospitals that see a number of cases and know what they're doing, and keep in contact with your fertility unit. So that was 25 years ago, but things have changed. About must have been getting on for a decade now, what we have found that using a different trigger injection, not HCG, not the pregnancy hormone, but using what's called an agonist trigger, we can actually avoid it in 99.9% of cases. And what we end up with that is, although the estrogen levels are high, that impact on the changes in biochemistry just don't occur. The ones that cause leakage of the blood vessels does not appear to occur. We understand that's actually because the difference between the two is that the agonist trigger actually produces a natural trigger of pituitary hormone, the LH it's called, whereas the HCG injection did it itself, and it lasted 72 to 100 hours, much longer than the natural surge of LH that we get, which only lasts 24 hours. And we think that's the difference. The downside of the agonist, what we call the agonist trigger, is that it also crashes the rest of the cycle. So if we do a cycle where we think we might get OHSS and we use the agonist trigger, the general view is that we should freeze the embryos that we create, and you don't have a fresh transfer in that cycle. And that's probably not too bad, because the lining of the womb in those cycles is very thick, and it may well be detrimental to the implantation of a pregnancy anyway. And these days, with the freezing techniques that we have, a frozen embryo has as much chance of getting a baby as a fresh transfer. So with those two things, the new trigger and the fact that we are able to freeze embryos with the understanding that the transfer of those will be excellent, we basically now have avoided in most cases. I mean, the statistics in Australia, if we go back 20 years, severe hyperstimulation with admission to hospital accounted for 2 to 3% of all IVF cycles. It's now down to less than 1%, because there still are surprises in terms of a relatively low estrogen level and still getting the OHSS, but it's always a mild form. And there also are still clinics who persist in using HCG despite the evidence that it's the wrong thing to do in risk possible OHSS patients. So there are, as I say, that's still a worry to me, that because in my hospital we see quite a few cases, and they are from clinics who don't follow the modern regime, the agonist trigger. It's something to have in the back of your mind, and when you sign your consent forms for treatment, you are actually saying that you know about OHSS and that you're accepting that small risk. These days, severe cases that end up in ICU, if we use our new technology and our new regime, is probably 1 in 200 or 300 cases. So very, very rare. Really, these days, little to worry about. But all the things that you read in the literature.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.